Good afternoon, Mr. Chairman, ladies, gentlemen. I will present you a comparison of mortality and ICD therapies in elderly versus younger adults in a long-term follow-up. As we know, implantable cardioverter defibrillator therapies decreases arrhythmic and all-cause mortality in patients at high risk of sudden cardiac death. Elderly people are increasingly considered for cardiac interventions, but the magnitude of the survival benefit is still not well defined. We can see controversial results in ICD benefit in the MEDIT2 and SCD-HEF main trials of primary prevention. Actual guidelines are based in several clinical trials that have expanded ICD indications, but the elderly have been poorly represented in these studies. We can see in this table the mean age of the population included in the principal trial for primary prevention or secondary prevention of sudden cardiac death. Probably only the age shouldn't be a limitation for the indication of an ICD. The purpose of our study was to assess mortality and ICD therapies during a long-term follow-up of elderly compared with younger adults. From June 2004 to June 2011, demographic, clinical, and survival data were collected prospectively in consecutive patients who received an ICD implantation for primary or secondary prevention of sudden cardiac death. Elderly and adults with idiopathic dilated cardiomyopathy or ischemic cardiomyopathy were included. All-cause mortality, cardiovascular mortality, appropriate and inappropriate therapies, and combined endpoint of time to heart transplant or death were assessed. Follow-up was made by in-office or remote monitoring controls. The cause of death was determined reviewing hospital clinical records or by the information of their relatives. Device therapies were classified as appropriate or inappropriate based on clear information, including anti-tachycardia pacing, cardioversion, or defibrillation. All p-values less than 0.05 were considered statistically significant. From 233 patients, 67 elderly with a mean age of 74.5 years and adults, 166 adults with a mean age of 57.8 years were included. The median follow-up time was 33 months and were followed 99% of the patients at least for 1 year. Comparing baseline characteristics, there was no significant difference between groups in the prevalence of male sex, primary prevention, functional class, heart failure admissions, non-sustained ventricular tachycardia, drugs, diabetes, or low hematocrit. There was a higher prevalence in the elderly group of idiopathic etiology, and they have a higher left ventricular ejection fraction. Also, we can observe a higher prevalence, a significant higher prevalence of stroke, hypertension, and impaired renal function. Talking about incidence of ICD therapies and mortality, there was no difference in appropriate therapies and inappropriate therapies between groups. There was a significantly higher overall mortality in the elderly, but there was not in the cardiovascular mortality. 16 elderly and 47 adults received an appropriate shock during the follow-up. In the first year, 62% of the elderly and 44% of the adults received their first appropriate shock. It's important to note that almost all the elderly patients received their first appropriate shock in the first 2 years from ICD implants. There was no difference in the survival time free of death or heart transplant, and it's worth note that 8% of the adult patients received a heart transplant in the follow-up. The most frequent cause of heart failure was, the most frequent cause of death was heart failure, followed by infectious disease, no device related. In conclusion, in our study population, elderly patients had a significantly higher all-cause mortality, probably due to their comorbidities. The incidence of ICD therapies, long-term survival time free of heart transplant or death, and cardiovascular mortality was similar in both groups. ICD therapy was effective for the treatment of potentially life-threatening arrhythmias in all age groups, and this finding support ICD implantation in elderly patients for the prevention of sudden cardiac death. Thank you for your attention.